Good day. Like in lesson 1 and CTG 1, you have already seen the CTG, you already filled in your quiz, you already answered your questions, you already got feedback on which of your answers were right and wrong. So again, in this lesson, I'm just going to discuss the CTG and the interpretation of the CTG with you, and specifically also looking at the classification of the CTG. How do we classify it and where does it fall? Now, here's the general impression, general CTG. As I've said, you have received it and you have looked at it. I broke it down a little bit to discuss the different parts of the CTG separately. Now, if we look at this CTG a little bit closer, first of all, we need to determine the baseline. Remember, that's always the first thing that we need to determine, and you see this on this yellow line here. And remember, the definition of a baseline is that we determine the fetal heart rate between periodic changes. So we need to, there are many decelerations there. These red squares indicate more or less decelerations. So we need to look at the fetal heart rate between them. And here you can see the green lines help us to determine the variability. We draw a line at the bottom of the fetal heart and we draw a line at the top of the fetal heart. And here you can see that the fetal heart rate varies with less than 5 beats per minute. So our variability is reduced because we say that the normal variability is between 5 and 25 beats per minute, so in this case it's reduced. Then if we look at the decelerations, and we will talk about the decelerations in more detail on the next slide, but if you look at these decelerations, there are some very small ones. They are too small to really meet the criteria of a deceleration. Remember, a deceleration is when the fetal heart rate decelerates with or goes down with more than 15 beats per minute for longer than 15 seconds. And these are not even 15 beats per minute. So there are some decelerations, but then there are some deeper decelerations, which is definitely more than 15 beats per minute and definitely longer than 15 seconds. So there are at least 1, 2, 3, 4 decelerations, and they are with more or less all of them are being, except that one, are being accompanied by contractions, but then there are quite a few contractions that are not being accompanied by decelerations. So if we look at this, there might be less than 50%, there are decelerations with less than 50% of the contractions in this case. Now, obviously, we need to see a little bit longer, we need to see a little bit more of this CTG tracing to see what's going on here and to see what's going on with the contractions there. Now, if we look at the contractions, we've said that the speed of this paper is more or less 1 centimeter per minute. So that will be a centimeter, or between the two rows of numbers is usually a 10 centimeter period. So in this 10 centimeter period here we see 1, 2, 3 contractions, 4 contractions, and these 1, 2, 3, 4 contractions. So they're more or less 4 contractions in 10 minutes. So to summarize what we saw on this slide is our baseline is abnormal, it's 165, so we have tachycardia, or at least borderline tachycardia, and we have reduced variability because our variability is less than 5 beats per minute. We have some decelerations here, and we will talk about the decelerations in more detail on the next slide. And then we have more or less 4 contractions in 10 minutes. And you can see these contractions are very coordinated. They are, because they are shortly on each other, so there's very little time, sometimes here, for example, where the uterus really relaxes between the contractions. And even here, there's a very short period between the contractions where the uterus relaxes. There are some coupled contractions which also causes a very small time period for the uterus to really relax. Okay, so if we look at this slide here of the same CTG that we are talking about, we are on this slide we are only going to focus on the decelerations as such. Now, normally when we look at decelerations, like I've said in the previous lesson, we look at four things. We look at the relationship of the contractions and the decelerations to each other. We look at the form of the decelerations, we look at the duration of the decelerations, and we look at the amplitude of the decelerations and how quickly they recover and go back to the baseline. So if we look at the relationship between the decelerations and the contractions, we see that there's almost no relationship. There's some decelerations like in here where there are almost no contractions, and also we're not 100% sure that these contractions are being recorded accurately because it looks a little bit, I almost want to say chaotic with the contractions. But there's, for example, a deceleration without a contraction. There's a deceleration that falls just behind the contraction. There's a deceleration that falls here between these two contractions. So there's not really a pattern between the decelerations and the contractions. There's a long part of fetal heart there where there are contractions without decelerations, and here again, because these decelerations, they are decelerations, but they are very small. They don't meet the criteria of a deceleration. We've said the deceleration is where the fetal heart rate decelerates with more than 15 beats per minute, and this is too small. So if we look at these bigger decelerations, we see that there's no uniformity in their form either. They are V-shaped and they don't have any shoulders here, but there's a little bit of a longer deceleration. So they all look different. And then if we look at the duration of the decelerations, this one is 60 seconds long. It's about a minute long. That one is about 60 seconds long. This one is a little bit longer than 60 seconds, but more or less 60 seconds. They are decelerating from, there's just above 160 beats per minute, and they're coming here to about 120 beats per minute. So it's about a 40 beats per minute deceleration. So if we talk and look again about the 60-60 rule, where we've said that if variable decelerations, and we say this is variable decelerations because they vary in form, they're not really a relationship between them and the contractions, and they're all V-shaped. So if we look at the variable decelerations and we talk about the 60-60 rule, we say that a variable deceleration should not be longer than 60 seconds, and they shouldn't be deeper than 60 seconds or decelerated with more than 60 seconds. So in this case, we still have, I almost want to call it, normal variable decelerations. So if we look at the figure classification and the figure guidelines of this regarding this CTG, and remember we've said the figure guidelines divide the characteristics of the CTG in normal, suspicious, and pathological. So if we look at the heart rate, the baseline, we see normal is 110 to 160, so it's just not normal. Abnormal pathological is less than 100 beats per minute. So this tachycardia of 165 will fall here in the suspicious group where it says one of the characteristics of the CTG is not in the normal limits. So the baseline heart rate is not here. When we look at the variability, we see that there's reduced variability. And FIGO says if there's reduced variability, it makes the fetal heart rate or this pattern pathological. And then if we look at the variable decelerations, it's still within normal limits in the sense that they are within the 60-60 limits. So they will fall also here under the suspicious column, in the sense that they're not pathological yet, but they are suspicious. But in total, our pattern would then be pathological because of the reduced variability. So there's a high probability of hypoxia. So we have to immediately act and act on this whole situation, which we will come to just now. So if we look at our NICE guidelines, remember NICE guidelines are being divided into normal and reassuring, non-reassuring, and abnormal. So if we look at our baseline, they say that the normal baseline is here 100 to 160. So ours are just above that. So and then they say in the non-reassuring column here, they say it's a baseline of 161 to 180 beats per minute. So in our case, our baseline will fall into this non-reassuring column. If we look at the variability, they group, if there's 5 or more variability, it's normal or reassuring, or less than 5 for 30 minutes or to 90 minutes, it is a non-reassuring sign. Now, our CTG is not long enough to really to be able to determine that. I think our CTG is about at the most 20 minutes long. So we can't really 100% say that this was for 30 to 90 minutes, but let's assume. So we can say that because of our variability, it falls in the non-reassuring column. And then when we look at our decelerations, normal is there's none or early decelerations. So we have decelerations and they're not early decelerations, so we're not normal anymore. So if we look at the non-reassuring column of variable and or late decelerations, we have said that our decelerations are variable and that they are less than 60 seconds long and less than 60 beats per minute. So they will fall in this category. They say also for over 90 minutes, but as we've said, we haven't made our CTG long enough to really see whether we meet this criteria. And occurring of over 50% of our contractions, I would say we are less than 50% also on this little piece of paper that we have, but I would say more or less we fall into this category. And if we now have initiated some resuscitation measures and it doesn't work and it becomes more pathologic, we might move into this pathological column. Now, you also needed to answer whether this is what is the most significant type of hypoxia indicated in this CTG. Now, at the moment, the big thing is the hypoxia is not coming or being associated with the variable decelerations, because the variable decelerations are still within normal limits. But the hypoxia is being shown to us, or a sign of the sign of the hypoxia is the reduced variability, and this usually comes gradually. So it's a gradually evolving type of hypoxia. Now, is this a purely observational management appropriate now? No, because we sit with, according to the FIGO guidelines, with a pathological tracing, and according to the NICE guidelines, with a non-reassuring tracing. So we definitely can't only observe the situation. We need to really manage the situation, and we really need to start with intrauterine resuscitation measures. So if we look at our management of this CTG, it's basically similar to our previous CTG, the one that we've discussed in the first CTG. We have to evaluate the factors that might reduce the fetal oxygenation. We need to look at the stage and the progress of labor. So depending on whether the patient is close to labor or still the cervix is still a small, little dilated, then it will obviously influence our behavior. We need to initiate some resuscitative measures, and we need to continuously survey and do frequent reassessments with a continuous CTG in this case. And if the suspicious rate becomes normal, we're happy. And if it be persistently suspicious, we need to closely monitor for the development of some pathological traces. And if it becomes pathological, we need to resuscitate while we are preparing the patient for delivery, whether it's a normal delivery or vacuum delivery or a cesarean section. So if we look at the intrauterine resuscitation or the in utero resuscitation, and we do it according to the maternity guidelines of 2016 in South Africa, as we've done in the previous CTG, we see that we were supposed to perform a vaginal examination to determine or to exclude cord prolapse. We need to reposition the mother to make 100% sure that the blood flow to the uterus is maximized. So we need to turn her on a left or a right side and definitely make sure that she's not lying on her back. And then also the whole issue that we have addressed in the first lesson regarding the administration of oxygen. According to the maternal guidelines, we need to give not more than 6 liters per minute via face mask for approximately 20 to 30 minutes. And if it works, if the variability returns to a better normal values, then we can stop with this. And as we've said, there is not enough evidence for all this, but there is some evidence that hyperoxemia can have some adverse effects on the fetus, especially on the retina of the fetus. And we've also seen that fetal compromise is seldomly due to maternal hypoxia, except in cases where we have maternal cardiac conditions or pulmonary conditions. The maternal blood oxygen levels are usually normal. Now, also we need to improve the blood flow between the placenta and the fetus. Although we know that variable decelerations are not always, especially in this case where it's kind of normal variable decelerations, it's not really always associated with fetal compromise. But our big sign, as we have said previously, of fetal compromise in this case is the lack of variability. So we do want to increase the blood flow between the placenta and the fetus in order to reverse or try to reverse this hypoxia. And we do that by an intravenous infusion of bolus of ringus lactate followed by a normal IV infusion of ringus lactate. We also need to improve the placental perfusion in the case of uterine overstimulation, and specifically in the case where patients are being induced or labor has been augmented with oxytocin or with prostaglandins. We need to stop the administration of the oxytocin and the prostaglandins immediately. With oxytocin, it's easy because we just stop the IV infusion. With prostaglandins, it's not always that easy because sometimes it has been given orally or in the vagina, and the tablets have already been absorbed. If there is a tampon, we can easily remove the tampon. Especially in the case where the patient is waiting for a cesarean section, tocolysis can also be used to stop or to reduce the contractions and to reduce, obviously, the effect of the contractions on the fetal heart as well. And then Lastly, we have, and it should not be lastly, but we definitely have to explain the problem to the mother, because as we've said in the previous slides, she see all this commotion, people are worried, people are running around, and she knows something is wrong, and she has to be told and to be reassured that everything possible is being done for her baby. And that brings us to the end of this lesson. And like in the previous one, I really hope that you've learned something new and that you have enjoyed it. I see you in the next one.